Hello, everybody. Ms. Kofke here, coming to talk to you today about inflammation. If you have not already watched the lecture on immunity, you need to stop here and go back and watch the lecture on immunity before this one. This will make a lot more sense if you've already seen the lecture on immunity. Because inflammation is part of our immune response to things. So if you have not watched immunity, stop, go back and watch it. If you have, let's keep moving forward together. We are still in chapter 17 in your Med-Surg book. There was also a video on inflammation on LMS, or it was linked in your module to watch. If you haven't done so, that's okay. I'm going to go ahead and play that video for you now, but it is there on your module, so you can go back and watch it from there if you want to see it again without having to come all the way back into this video.
Inflammation is the protective reaction of vascularized tissue to local injury. Acute inflammation is the early, almost immediate reaction of tissue to the injury, and it is the first phase of wound healing. Acute inflammation can be triggered by cell or tissue damage, or by the presence of dead cells or noxious agents such as bacteria. Acute inflammation typically occurs before the immune response becomes established and aims primarily at removing the injury-causing agent and limiting the extent of tissue damage. Acute inflammation occurs in two overlapping stages, vascular and cellular. In the vascular stage, arterioles and venules near the site of injury constrict briefly, then dilate. Dilation promotes congestion, while an accompanying increase in capillary permeability leads to the movement of fluid into the affected tissue, resulting in the 5 classic signs of inflammation: redness, swelling, heat, pain, and loss of function. As fluid leaves the capillaries, the blood remaining in circulation becomes more viscous, it flows more slowly, and clotting occurs. The cellular stage of acute inflammation is initiated by the movement of phagocytic white blood cells, or leukocytes, into the area of injury. The leukocytes begin to adhere to the vessel wall, and then, in a process called emigration, squeeze through the wall and move into the inflamed tissue. The leukocytes wander through the tissue, guided by chemical signals in a process called chemotaxis. The cellular stage culminates in the leukocytes engulfing and degrading the bacteria and cellular debris in a process called phagocytosis. Products of phagocytosis, along with plasma and blood cells, form exudates, which accumulate, causing swelling and pain. Exudates are composed of serous fluid, red blood cells, fibrinogen, or tissue debris, and white blood cell breakdown products. Concurrent with the events of the vascular and cellular stages, chemical mediators release bioactive agents that act to mediate the inflammatory response. Mediators are derived from the cells or from plasma. One of the first mediators of an inflammatory response is a cell-derived mediator, histamine, found in high concentrations in the mast cells of connective tissues adjacent to blood vessels, as well as in blood basophils and platelets. Histamine is released in response to a variety of stimuli and causes dilation and increased permeability of capillaries. Serotonin, another cell-derived mediator, performs similar actions. The 3 major plasma-derived mediators are present in the plasma in precursor forms that must be activated, usually by a series of proteolytic enzymes. The kinins increase capillary permeability and stimulate pain receptors. The clotting system traps exudates, microorganisms, and foreign bodies. The complement cascade causes vasodilation, promotes leukocyte chemotaxis, and augments phagocytosis. Acute inflammation comprises a variety of complex protective responses to injury that together lay the groundwork for the next stages of the body's recovery: immune response and tissue repair.
Okay, so don't panic if you watch that video and it was very, very, very um, in-depth anatomy. We're not going to go quite as in-depth for what we need to know, so don't panic there. And you've already gone through immunity, so you probably have, hopefully have at least a little bit of a grasp on some of these things that we'll talk about. So inflammation is going to be part of that response by the body to be immunocompetent and to have a healthy immune system. Then your body needs to be able to have the ability and the opportunity for that inflammatory process to jump in and start to take over. So with inflammation, it provides immediate protection against the effects of tissue injury and any invading foreign proteins. So inflammation is the body's response to something harmful. That could be something physical, like an actual direct injury. That could be a chemical, or that could be infectious. So that could be a bacteria or virus as well. It is a localized reaction. It's to neutralize, control, and eliminate the offending agent, and then to prepare the site for repair. Excuse me. It is non-specific. So it doesn't, unlike, say, the antibodies that go in and they attack specific things, inflammation is exactly the same across the board, no matter what happened to cause it to be triggered. So if you got a bee sting or a sore throat or have a surgical incision, if you got burned, any of those things are going to cause, any of those injuries or infections are going to cause an inflammatory response. That inflammatory response is going to be the same, no matter where it happened, no matter what the reason was for it happened. The stages of the inflammatory response are going to be the same. So inflammation also occurs to cell injury. So if you had a stroke or a heart attack, myocardial infarction, when those cells stop receiving oxygen and they start to die off, that's going to cause an inflammatory reaction as well. It is protective. The goal is to contain and control and eliminate whatever's causing the inflammation, whatever that cause for injury was. It is to protect the rest of the body. So it wants to get rid of it before there's more damage. So when you see that suffix of itis, it's going to mean that there's some inflammatory process taking place. And I bet you guys have probably just about all of you have taken care of somebody or have had yourself some sort of a inflammatory response where you had the last name itis, like arthritis, appendicitis, bronchitis. So it's just describing where that inflammation is. So appendicitis is an inflammatory process is happening in the appendix. Conjunctivitis is happening in the conjunctiva of the eye, and so on. All right, so we pretty much kind of talked about these causes of inflammatory response on the previous slide, but we're still going to hit on those. So it could be a physical chemical injury. So trauma, a burn, that's going to include frostbite, any kind of toxic chemical or radiation also. An infection. So remember, infection is just one cause of an inflammatory response. They're not the same thing. The inflammatory response and immunity come in response to an infectious agent. So infection and inflammatory response are not the same thing. Immune response, so an overactive response to whatever caused that immune system to respond. So this is when we're talking about, like, if a allergic agent has been identified and there's a anaphylactic response, would be an overaction, but it could also be just your normal immune response to an an antigen that is not belonging in your body. And then again, death of tissue. So tissue necrosis can also will also lead to an inflammatory reaction. So it could be acute. Acute inflammation is an immediate onset, usually lasting 1 to 2 weeks. It is protective in function, and its goal is to remove whatever's causing the inflammation and then limit the amount of injury. So think about short-term injuries like cuts, small burns, things like that. Chronic inflammation is if that injury persists and the body can't contain it or neutralize that damaging agent, then it's going to continue. So this inflammatory process will just continue. So this may persist for years with symptoms becoming progressively worse, like in rheumatoid arthritis or lupus, and other autoimmune diseases. Remember, we talked about autoimmune diseases briefly and immunity. So the body is not able to differentiate self versus non-self. So it is identifying self antigens as non-self, and then is attacking them. And so that's leading to a chronic inflammatory response when that's an ongoing issue. So this can be debilitating and has long-lasting effects. When these cells move in, when this inflammatory response happens, sometimes there's tissue damage and those tissues die. It can lead to scar tissue and fibrosis, and lead to permanent tissue damage and loss of function in those areas. Excuse me. The inflammatory response is going to occur in predictable 3-stage sequence. So there's going to be vascular changes, and then there will be cellular changes, and then there's recovery is your last stage. The sequence is always the same regardless of what the triggering event is. The responses at the tissue level, if you have a tissue level response, this sequence is going to lead to the 5 cardinal symptoms of inflammation, which are going to be warmth, redness, swelling, pain, and decreased function. So we'll talk some more about those moving forward. So the timing of these stages may overlap. For instance, you may not be all the way through stage 1 before stage 2 starts. There's going to be overlap. And same with, you still may be seeing stage 1 happening, stage 2 happening, and recovery starting to happen at the same time. So they will go through these 3 stages in this order, but there may be some overlap. So this first stage is going to have to do with the vascular changes that we see. So something happens to cause an inflammatory response. When this happens, we're going to see a lot of changes in the microcirculation. We will see a constriction of those small veins. So then it's going to block the blood return. It's not going to block it, but it's going to slow down and cause a traffic jam of blood trying to get back up to the heart. It's also going to cause vasodilation of those arteries and those small arterioles at the area of injury, and increase vascular permeability and the ability for the white blood cells and to infiltrate that area. So the injured tissues, when that vasodilation happens, the injured tissues and the leukocytes in that area will start to secrete histamine, serotonin, and kinins that constrict those small veins and dilate the arterioles. That's going to lead to redness and warmth at that tissue level. So remember, where you see redness, where you see warmth, you're looking at increased blood there at that area. So that anytime you see an increase in warmth or an increase in redness somewhere, that's what you're looking at, is that there's some vasodilation bringing those arteries up to the surface. So that increased blood flow will help to deliver nutrients to that injured tissue. But that increased blood flow, that's what's going to cause that throbbing you feel whenever you have smashed your finger in a car door. That is those arterioles opening up and allowing that blood to just bring in things to help to heal that injured tissue and to remove anything that it shouldn't be there. That increased capillary permeability will allow the cells to move from inside the blood vessels to outside the blood vessels into this interstitial space, getting needed cells to the site, and then that's going to lead to an increase in edema. That edema will help to protect that area from further injury by causing a cushion to happen there. So these things happen usually immediately, pretty quickly on onset of injury, but depending on the severity of the event that led to it, these vascular changes will typically subside within 24 to 72 hours. So as we've looked at those vascular changes, remember, let's go back to those 5 cardinal signs of inflammation. So warmth, redness, swelling, we've seen all of these as in this stage of vascular changes. Okay, so let's look at stage 2, which has to do with the cellular response and the cellular changes that happen. So stage 2 is going to involve that. So it's going to be when the exudate happens. So exudate happens in the form of, or like pus that you see, contains dead white blood cells, necrotic tissue, fluid, and the fluids that escape from the damaged cell. So when the injury happens, let's talk about the phagocytosis that goes on. The leukocytes move in. So remember, the leukocytes are the WBCs, the white blood cells. They move in to engulf, eat, digest infection or dead cells or whatever caused the inflammation. They want to get it and get it out. Neutrophils are the first ones on the scene with acute inflammation. So as those leukocytes move in, monocytes will go in and go through that phagocytosis and the macrophages eating and getting rid of. The lymphocytes, the T and B cells move in with antibodies and immune response, and an immune response will start to take place if applicable. So remember that if your cause of your inflammation is a immune problem, then that's where you'll see, a allergic reaction problem. That's when you'll see that immune response starting to take place. But they'll also obviously start going in if it is an infectious process as well. So then there is the release of chemical mediators. So histamine is causes vasodilation and increased capillary permeability. So that's going to continue to take place. And then kinins also lead to vasodilation and increased permeability. They also send out messages to the neutrophils saying, hey guys, we need some help over here. We've got something that has damaged us or some foreign agent that's coming in. Prostaglandins are also released and also increase permeability. So let's look at this chart over here for just a second. What we see here, hold on, let me change my pen color because it's on blue and I feel like it won't be able to be seen as good. Okay, so we've got the disruption of tissue integrity, and what's going to happen then? You're going to have an injury, you're going to have ischemic damage, or you're going to have an immune response. So one of those 3 things has happened. Basically, something has messed with the tissue. So that is going to lead to this inflammatory response. So now let's look into these first two stages. Remember that last stage is going to be recovery. So right now we're looking at the response. So we've got vascular changes and we've got cellular changes. So vascularly, we're going to see that vasodilation, increased capillary permeability, increased blood flow, local tissue congestion. So everything's going to get backed up. This is what's going to lead to these 5 cardinal things we see with inflammation. This is what you're going to see in your patient. Think about if you did close your fingers in the car door, you're going to have an injury, right? Let me change pen color again. You're going to have an injury then. That is going to start this inflammatory response. All this swelling and increased blood flow is going to bring red, it's going to cause it to be red. It's bringing that blood to the surface, that warmth coming along with it, the swelling with all that increased blood flow, all that together is going to lead to having pain there at that site. And loss of function is really about all that inflammatory, all that inflammation and swelling, and the pain is what's going to lead to that loss of function. So it's just going to make it difficult with the example of if you close your finger in the car door, now it's swollen up and you can't hardly bend it. So that's what's happened. You can't use that. It's painful and it's swollen and you've lost your normal function of it until all that inflammation resolves. So next up, we've got, I'm going to go ahead and erase some of my pink over here so it's less, or my stuff that's over here so it's less confusing. Okay, so next up we have, if you went to, is the cellular changes. So same thing happens. What's going to happen at the cellular level? We've got those monocytes coming in. They're increased there at the area. They're coming in. They're eating up all the bad stuff that shouldn't be there and leaving behind the exudate, the old white blood cells, the side particles that are left behind. And then they're also releasing chemical mediators to help bring more leukocytes and help to the site of injury. What's going to happen here is you're going to see the systemic effects. With cellular changes, it's going to lead to those systemic effects that we'll see. So that's when you'll see that fever, elevated white blood cell count, just tiredness, not wanting to eat, and eventually sepsis, which I'm not going to get into right now. Okay, so stage 3 is going to be the time for healing and regeneration. So stage 3 features tissue repair and replacement. Although this stage is going to be last, it begins at the time of the injury. And so it will, as was said earlier, those stages will overlap. So you will start repairing early. It begins at the time of as I said, it begins at the time of the injury and continues after whatever has been causing the inflammation is removed. So one of two things are going to happen. You'll either get regeneration or replacement. So regeneration is only going to be for cells that can regenerate. There are some cells in your body that multiply constantly, like skin cells and GI cells. And some cells have just parts of them that can regenerate, like the axons on a nerve. Some cells can regenerate only as needed, sometimes in your kidney, liver, and pancreas. If they're functioning normally, then sometimes you'll see regeneration there. But then there are cells in your body that cannot regenerate. They are not going to heal or replace themselves with what was already there. So that's going to be regeneration. An example of that's going to be your brain tissue or your cardiac tissue. If those things die, then they're dead. So what's going to happen if those things die is that you're going to replace them with epithelial cells or scar tissue. So that will basically then form a patch for what is there. So, but remember, scar tissue, it only serves as a patch. It's not going to function the same as the cells that are native to that area are. So, for example, if you had a heart attack and you had some necrotic tissue, you had some of the heart muscle destroyed during that heart attack, then the scar tissue is going to form there so that it's not a just ongoing ischemia. It doesn't continue to happen, and so that the cells don't continue to kill each other. So you're going to get scar tissue to serve as a patch, but that scar tissue can't squeeze like the cardiac muscle squeezes, so you won't see function there. But it will help to preserve what's left. Okay, so let's look at what you'll see when you're assessing your client. You will have those localized signs that we've already talked about, the redness or erythema, edema or swelling, warmth, pain, somehow loss of function, loss has gotten left off of there. So I'm going to write it on there as best I can. Function. Okay. So you may not completely lose function. That's it's really going to be just a decrease in ability for it to function at its normal level. So, and then we also talked about those systemic signs that have to do. Remember, these are going to have to do with those vascular changes, and these are going to have to do with those cellular changes. Okay. So, and so we've kind of already hit on those. Be familiar with the way that that inflammatory process is going to impact the way your patient feels and those signs and symptoms they'll feel with it. Also, be familiar with your lab and diagnostic tests that are going to be involved. So, just like with the immunity, we're going to want to see that WBC and differential. You may not see a change here. It's going to depend on the cause of the inflammatory response. You may see certain types of WBCs elevated if it is an acute or a chronic problem, like if you're having an acute inflammatory issue or infectious issue, then you may see the white blood cells elevated. Remember, you may, if there was infection or inflammation, and it's relative to an allergic reaction. Remember, you may see an increase in those eosinophils. So look back, connect those two things. I'm not going to go back over everything because I already went over it in immunity. But because of the causes that you can have to lead to an inflammatory response, there's going to be some overlap here because allergic responses, infectious responses, remember how closely tied that immunity and this inflammatory process are. And then let's look at some specific labs. So your ESR is your erythrocyte sedimentation rate. It measures the rate that the red blood cells separate from the plasma and fall to the bottom of the test tube. The faster it settles, the higher the number of cells. So it is a non-specific sign of infection. Increases, it could be, so it's non-specific, but it is something that we'll look at to help to point us towards an inflammatory process. Normal values are going to be 0 to 15 for men and 0 to 20 for women. The other one is the CRP or C-reactive protein test, which measures the level of one specific protein, where the ESR takes into account many proteins. The liver and endothelial cells produce CRP, which is a chemical byproduct in response to inflammation. So what we'll look at is anything over 3 could indicate an inflammatory response. So typically you will see that CRP or C-reactive protein used more frequently. It's a better indicator of inflammation than the ESR is. It's more sensitive and responds more quickly to changes in the clinical setting. So it's going to have, if you suspect a inflammatory response of coming on, it is going to change and reflect that that inflammatory response faster and sooner than a CRP would. Than the ESR would. So CRP is going to be a more reliable test that's going to respond more quickly to changes in the setting. So you'll see that instead of the ESR. Also, you more commonly see false negatives and false positive results with the ESR. Renal disease, females, older age, people in the older age groups, sometimes will just have an elevated ESR. So it's not as good at showing us acute things that are changing quickly. It does help with long-term monitoring, though. That ESR is something that they use more often with long-term monitoring than they do the CRP. And then lastly, organ-specific tests. If you suspect inflammation in a specific area of the body, then you want to look at organ-specific laboratory data. So if you suspect inflammation in the kidneys, then you want to look at that BUN and creatinine. If you suspect inflammation in the liver, then you want to look at those liver enzymes, like the ALT and the AST. And then lastly, what do we do to treat inflammation? So pharmacologic interventions are going to include steroid usage. So steroids are going to decrease that inflammation, but they also may mask the signs of infection because sometimes, you know, your body does these things and it's useful sometimes, right, to have that inflammatory response so you know something's going on. But if you're taking steroids, it may mask those signs of infection. It can elevate your blood glucose level. Steroids also should not be abruptly stopped. They have to be tapered up and down. NSAIDs or non-steroidal anti-inflammatory drugs, that category of medications can also be used to decrease inflammation, but they can often be overused and cause problems with the GI tract. So they're not usually recommended for long-term use. If you're experiencing inflammation in the GI tract, you can use probiotics to maintain normal flora of bacteria there. There are definitely foods that either can lead to an increased inflammation or decrease inflammation. Some things that are suggested to avoid is going to be dairy products, carbs, red meats, processed meats. All these things are going to lead to inflammation in the GI tract. So there are foods that can lead to a decrease in inflammation. And then as far as preventing, making sure that if you are getting appropriate rest and following guidelines and pharmacologic and nutritional interventions set by your healthcare provider. And that is going to do it for inflammation. So if you have any questions, please email me or put it in your unit forum. And so at this point, you've probably been through thermoregulation and immunity and inflammation. So if you have any questions on any of those, please let me know. Ms. Curley will be following up with infection, and that'll help to tie some of this together as well.